Hello, everyone, and welcome to our Regional Multicultural Monday webinar, Immunizations for Adults and Minority Populations Living with HIV and Reducing Vaccination Barriers. My name is Leonardo Aguilar, and I am a program coordinator for the South Florida AIDS Education and Training Center. Today's webinar is presented by Dr. Marilee Worley. She graduated from Temple School of Pharmacy and completed a 2-year of residency training. She is a board-certified infectious diseases specialist pharmacist and currently teaches at Nova Southeastern University College of Pharmacy. She practices at Palmetto General Hospital and also serves as a faculty for Southeast AETC. I want to let you know that this presentation is being recorded and the recording will be available for viewing by the end of the week. Now, we encourage and encourage participation during the webinar. So if you have any questions, we'll have questions being answered by the end of the webinar, but you can feel free to type them in the Q&A box, the chat box, or you can raise your hand to have your mic unmuted. If you hover over the bottom side of the screen, you should be able to see the controls and therefore be able to ask questions or type in the Q&A or raise your hand. Raise your hand icons appear next to the Q&A and chat box. There will be an evaluation at the end of the event. Your feedback is extremely important to us, and evaluations are also a HRSA requirement for continued findings. We like, as an initiative, to really reflect on how this can actually impact your practice with clients and patients. And think of when you're hearing this webinar at the end, just give us your input in how do you think this could apply in your practice and your overall just treating patients and talking. And I know HRSA and ourselves, we really want to know really how this is, if we're doing a good job at really engaging you. And so it is extremely important to us what you think, how you reflect on how this applies to you and your practice. As far as CME and CE credits, there will be an email sent to you alongside with the evaluation link. The evaluation link should pop out at the end of this webinar, and if it doesn't, there will be a follow-up email with information with CE credits and CME credits. There will be, for CE credits, you'll follow a link, and for CME credits, there will be an credit adjustment form that will also be emailed to you, and then you'll save with the first name and last name and email to the email that will be provided in email. All directions for CE and CME credits will be emailed to you. Just bear with us, so whoever participated in this webinar will be able to get CE and CME credits and the board that you're certified in. So it's important to know that CMEs and CE credits will only be issued to those participants who registered, attended, and actually completed an evaluation. So that's enough of me talking and saying a lot of things which are important, but the most important thing is here to learn. And without any further ado, I would like to present you our today's speaker, Dr. Marilee Worley. Dr. Worley?
Thank you so much for that introduction. So today I'm going to be talking about immunizations for adults in minority populations living with HIV and reducing vaccination barriers. Disclosures for this activity are that I have no financial relationships or commercial entities to disclose, and I don't have any reason to really talk about any off-label use or investigational product use, because I'm going to be discussing the current approved uses of vaccines in our patient population. Objectives for today's lecture include describing the differences in immunization requirements in persons living with HIV. Additionally, I hope that you all will be able to recommend appropriate vaccinations to adults and geriatric persons living with HIV. I will focus on adult population because pediatric population would be a whole different lecture on it in itself. Additionally, one of the big things that we want to focus as is hopefully discussing barriers to vaccine uptake in persons with HIV specifically minority populations, and really focusing on trying to reduce barriers and what kind of strategies have been studied to reduce vaccine barriers in this patient population. All right, so a little bit of background on the importance of vaccinations. Persons living with HIV are at an increased risk of many different infections. As many of you all know, since you do work in this patient population, it's not just HIV that's the infection that these patients are at risk of complications from. A number of, oh, sorry, the slide went ahead. Go back. Sorry. A number of different infections are known to increase in risk in this patient population, even in the era of highly active antiretroviral therapy. It has been shown that there's a higher risk of both disease incidence as well as severity of pneumonia due to Streptococcus pneumoniae as well as influenza. There's also a higher risk of disease progression, such as disease progression to cirrhosis and hepatocellular carcinoma in patients living with HIV that are also co-infected with hepatitis B. There's also a higher risk and a more rapid progression of cancers caused by the oncovirus, human papillomavirus, or HPV. So HPV-related cancers in a lot of patient populations are actually unaware of how many cancers are actually HPV related, are definitely a higher risk in this population. And it's not just cervical cancer. So we'll talk about that and some of the barrier reduction strategies. Sorry, the slide shows. I need you to progress the slides, sorry. Okay. Sorry, we're working on a couple technical difficulties here. I'm just gonna go through. Okay, so a little bit of data, because I'm a data person, I love to talk about numbers. So looking at some of the numbers, how high of a risk in our patients living with HIV compared to the non-HIV impacted population when we're looking at diseases such as Streptococcus pneumonia and influenza virus. In a study, and this is in a population that is in the era of highly active antiretroviral therapy, they showed that even though overall the rates of invasive pneumococcal disease, or IPD, have decreased in the general population and everyone, and even it has decreased in the HIV population as well, compared to the non-HIV population, patients living with HIV are still at a much higher risk, and it's about a 7-fold risk with the adjusted risk ratio of 6.6, and you can see the confidence interval there. I wanted to point that out because a lot of people are hearing about the great response and the great things that are happening with pneumococcal disease decreasing in the incidence. However, we still have to make sure that we're protecting the populations that are at greater risk of acquiring this disease. Higher disease risk and progression of disease with hepatitis B is also noted. When we're looking at this, the all-cause mortality is so much higher in men with HIV than those without. When we're looking at this, the risk is about 33.8 when we're looking at some of the statistical relative risks there. Additionally, when we're looking at progression of HPV-related cancers compared to the general population, when we're looking at standardized incidence ratios, the risk of rapid progression is much higher. Depending on the different types of cancer, when we're looking at cervical cancer versus anal cancer, the risk is much higher. Next slide. Okay. Overall, there's a couple different strategies that we can do as healthcare providers to reduce the risk of infectious diseases in our patients living with HIV. One of those main things that we always talk about is making sure all of our patients get active antiretroviral therapy and they're able to maintain their regimens and continue them as recommended by our healthcare providers, because we know that antiretroviral status, meaning if they're on antiretrovirals and they're virally suppressed, is one of the biggest factors in reducing our overall infectious disease risk in this patient population. Because once we get their immune system back up and going, they're at much lower risk of many different infectious diseases. But in addition to this, we can also recommend and discuss behavioral risk modification strategies. Some of these include discussing smoking cessation with our patients. This has been shown to reduce the risk of influenza and pneumonia in all of our patient populations. Additionally, talking about safe sex, which would prevent the risk of acquiring some of our sexually transmitted diseases. All right, so additionally, we do recommend prophylaxis with certain anti-infectives such as Bactrim in some of our patient populations that have lower CD4 counts. So that can reduce certain infectious diseases. But the last one, the main one that I'm going to focus on today, is vaccinations. Making sure our patient populations have a complete vaccination schedule and profile is one of the things that we can really help reduce the overall infectious disease risk in our patients living with HIV. There are some important considerations to think about when we're evaluating our patients for whether or not they would maybe need to get new vaccines. First of all, we need to make sure that we do stress the part that vaccines are a key component. It's part of the whole picture, making sure that we're ensuring the health of our patients and persons living with HIV. Additionally, especially in the South Florida area where I'm from, but I'm sure it's the same in a lot of other places in the country, people who are born in other countries may have actually had an incomplete childhood vaccine record. So it's entirely possible that your 30 or 40-year-old patient actually never got the hepatitis B vaccine series potentially when they were a child because they grew up in some other country that was not part of their traditional health program. Additionally, when we're thinking about this, we might even have to think about some childhood vaccines that that persons living with HIV are recommended to get when they haven't had their childhood vaccines, like when we're thinking about MMR or varicella. Some of these only have an indication based off of their CD4 count though, because these are live vaccines, and I'll talk about those a little bit later. ACIP through the CDC does come up with a schedule every year in February for recommending vaccines in our patient population. When we look at the schedule of the ACIP vaccine schedule for adults, there's two different tables, and table 2 really focuses on indication specific or medical conditions that might alter your vaccine schedule. And I have here the table 2 that discusses that. And you can see up at the top, there's HIV infection, and they have it broken down by CD4 count. That is one of the potential medical conditions that would have additional vaccine indications compared to the general population. And we will discuss the differences throughout the presentation. All right, so looking at some of the immunizations that are recommended for the general population, and of course our population of patients living with HIV would additionally need these vaccines as well. Influenza vaccine. I can't highlight this enough as a pharmacist. I'm sure everyone is aware how much we really love talking about the flu shots, but getting the flu shot every year is very important for helping prevent patients living with HIV or just general population patients from getting influenza. Additionally, it can help prevent some of the severity of influenza infection. Even if it doesn't prevent the influenza infection itself, it might prevent hospitalization due to severity of influenza, because if they have partial immunity, they might be able to fight it off a little better than if they hadn't seen the vaccine in general. The next one is the tetanus shot, and this one is, of course, recommended for the general population as well as our population living with HIV. And then the human papillomavirus vaccine, or HPV vaccine, is recommended in the general population as well as the population, our patients living with HIV. The main difference here is that it's a 3-dose series, and I'll discuss a little bit more about that on the individual HPV slide. All right, so some additional considerations that might vary from compared to the general population that is a little bit different in those living with HIV include the pneumococcal vaccines. And so we do recommend both the 13-valent pneumococcal conjugate vaccine as well as the 23-valent pneumococcal polysaccharide vaccine. Then we also recommend the meningococcal vaccine. And this is a difference or a variation compared to the general population or patients not living with HIV, because this is not generally recommended in all patients, but it is recommended in all patients living with HIV. Hepatitis B vaccine is definitely recommended, and it's one of the, there are some additional considerations in persons living with HIV because they are at increased risk. And then hepatitis A vaccine. There's a recent recommendation that's actually updated, and it's pending official MMWR stamp, which is really when these vaccine recommendations are officially recommended through the CDC. However, they've already voted on it in a meeting in June, and we're waiting for the publication for the exact wordage on the new hepatitis A vaccine recommendation. So a little bit of discussion of what are the two different pneumococcal vaccines. Well, one of them is a 13-valent conjugate vaccine. And then one of them is a 23-valent polysaccharide vaccine. Well, what does this mean? The valency really just means how many different serotypes of pneumococcal or strep pneumo that they put in the vaccine. Since Streptococcus pneumoniae bacteria make different antigens on the outside of their capsules, they are antigenically different. And so the unfortunate thing is that when they change their capsules, they can evade our immune memory cells, and they can really hide from our antibodies. And so this really necessitates the need to put additional strains in these vaccines in order for our immune system to be able to recognize the different antigens that are presented on the outside of this bacteria. So with the conjugate vaccine, we have 13 different types of pneumococcal bacteria antigens that are included in this vaccine. The cool thing about conjugate vaccines is that it does induce a T-cell dependent immune response, which helps with maturation of B-cell response and generates a little bit more immune memory. This is really what leads to potentially why the ACIP and evidence suggests that this vaccine does not need as many booster shots as maybe a polysaccharide vaccine would, which the polysaccharide vaccine is a T-cell independent immune response. So really its immunity is limited to potentially only 3 to 5 years. Now, the difference in these vaccines really informs why we have the schedule that we have from the ACIP, which is published in the MMWR, as I have referenced in this slide here. So what the current recommendation is, if you have a patient that is naive to the pneumococcal vaccines, you would start off with giving the conjugated vaccine, the 13-valent PCV, or Prevnar is the brand, 13 vaccine. And then at least 8 weeks later, because we don't want to interfere with the immune response from the conjugated vaccine or have that conjugated vaccine immune response interfere with a polysaccharide vaccine. That's why we have to separate it by at least 8 weeks. So after 8 weeks, then it's time to be able to give the pneumococcal polysaccharide vaccine, and that's the PPSV23. And after 5 years, they do have an indication to get a second dose. And this is where things get a little bit complicated, because then really they shouldn't be getting a third dose until after they've turned 65. And it has to be at least 5 years since their last time that they got the pneumococcal polysaccharide vaccine, according to the current schedule, with a recommended lifetime dose of 3 doses for the PPSV vaccine. All right, so a little bit about the hepatitis B vaccine recommendations. According to the HIV primary care guidelines, they do recommend that all persons living with HIV should be screened for evidence of hepatitis B virus infection upon initiation of care. So before we start any antiretrovirals, or at least at that same visit, we need to make sure that we're screening patients for hepatitis B, because we do know as healthcare providers and providers of patients living with HIV that this may actually impact our antiretroviral choices, as well as some of the additional disease management strategies that we do with monitoring. So they do recommend to get the surface antigen as well as antibody antibody to core antigen upon initiation of care. And then once you see the results back, that patients that are still susceptible to hepatitis B, meaning that they're not showing proof of immunity, really need to go ahead with the vaccine series, and they should be vaccinated. And according to the ACIP as well as CDC that work together, they do recommend hepatitis B vaccination for all susceptible patients, regardless of HIV status. So according to the recommendation though, there's really no specific dosing or alternative vaccine strategy that's recommended over any other when we're looking at vaccinating our patient population. And we're going to talk about some of the controversies of vaccines that really does impact our patient population, because we do know that we do have a lower response rates traditionally compared to the HIV uninfected population when we're looking at responses to hepatitis B vaccine. But the current recommendations say modified dosing regimens, including the doubling of the standard dose, as well as the administration of any additional doses. They might increase response rates. There are some studies that suggest that, but the data on this alternative schedule are limited, so they're not really recommending one over another. They're just saying, please vaccinate. So that's the main thing that they're recommending. And there's 3 options available. And I have here a chart that's available on the CDC that really discusses the current available FDA approved and recommended vaccines in the United States that are available for protecting against hepatitis B. So when we're looking at our single antigen vaccines, we have Recombavax HB, we also have Energix B, and we have a new one called Lisfav, sorry, I butchered that brand name. And so we really have 3 potential options here. When I'm looking at the differences between these options, one of them, Energix B, it has a 1 ml dose that has 20 micrograms of dose available, which is enough for most of our standard population, as well as if we're doing the standard dosing, we wouldn't need to be giving more than that. However, in some studies, some providers do wish to give a 40 microgram dose, which is the dialysis formulation of Recombavax HB. If you were to want to give a 40 microgram dose of Energix B, which has been studied, you would actually have to give 2 injections at one site at that visit. And so there is an alternative strategy, but it does require a little bit more injections. And so the Recombavax HB has a dialysis formulation, which is already formulated into a 1 ml dose, which is able to be given just 1 shot. So you're able to give it in 1 syringe, but it is a special dialysis formulation. And this has been studied with a 3-dose schedule. So you would get the first dose and come back in 1 month, and then come back in 6 months. Now, a new vaccine that actually data with the HIV population is lacking in as far as what's currently published in our HIV population, a new vaccine has come out. It's an adjuvanted vaccine with a newer adjuvant. And so this vaccine is recommended to be administered 2 doses 1 month apart. And it was recently FDA approved. And so I included it here for completeness sake. However, I would say that data with HIV is lacking. And so we will see potentially if this is a good vaccine to recommend in our patient population. All right, so moving on from hepatitis B, now we're moving on to hepatitis A. So this is actually something that's had a little bit of traction and a little bit of movement when we come to the overall recommendations, especially in our HIV population. So in June of 2019, which is only 2 months ago, the ACIP actually recommended to amend their hepatitis A recommendations, and they're now recommending it to all persons living with HIV that are older than the age of 1 year old to be routinely vaccinated against hepatitis A. So they don't need any additional risk factors. Just anyone living with HIV should get vaccinated with hepatitis A vaccine. It's still pending the official MMWR publication, so I have to put that little caveat in there. However, they did vote on this in the June meeting, and so we're anticipating a publication related to the exact words and the exact verbiage as related to this vaccine recommendation. However, prior to this, ACIP did recommend hepatitis A vaccine for anyone with the following risk factors, which included a lot of our patients living with HIV. So men who have sex with men, they were at higher risk of acquiring hepatitis A, and so that was traditionally recommended to this population. Additionally, injection drug users, that was an additional risk factor for hepatitis A, so this was hepatitis A vaccine was already recommended in that population. Additionally, travelers to countries with high endemicity of hepatitis A, or hepatitis A research lab workers, which of course you would expect they would have a higher risk of acquiring it. Persons with chronic liver disease, meaning that they were at higher risk of other liver complications if they were to get hepatitis A. They were traditionally also a patient population to target and make sure that they would get hepatitis A vaccine. A newer recommendation that was recommended, I believe, this past February were persons experiencing homelessness. And this was in response to a lot of hepatitis A outbreaks, actually, both in California and I think in Kentucky and a couple other places. There were a number of hepatitis A outbreaks in persons experiencing homelessness. And so that's what really prompted the ACIP and CDC to really recommend hepatitis A in this population. And clotting factor disorders, which was recently discussed at the June meeting, that was a historic recommendation for a hepatitis A vaccine as well. So what's available for hepatitis A vaccines? We have Havrix, which is a single antigen vaccine. It's available and it's a 2-dose vaccine series. So it's the 1 dose followed by a booster in about 6 to 12 months. Then we have Vacta, which is another single antigen hepatitis A vaccine, which is again a 2-dose series. So it's the first dose followed by a booster in 6 to 8 months. And then we have Twinrix, which is a dual antigen. So it has both hepatitis A as well as hepatitis B. And this is a recombinant vaccine. It's a 3-dose series. And the 3 doses is really just mostly because of the hepatitis B that's in there, right? Because usually hepatitis A only requires 1 dose. But if you start with one type of vaccine series, they do recommend to complete with the same vaccine, just because the data on switching vaccines is really not clear. So we would want to stick with the same component. So if you start with Twinrix, complete the series with Twinrix, and the same with the other 2 single antigen vaccine components. One thing I wanted to point out here is there is, with the Twinrix, there's an accelerated dosing series that could be recommended. And this is traditionally recommended in those who are traveling to somewhere that has a higher risk of hepatitis A. So maybe they're leaving for their trip in like a month and a half and they can't wait for the whole 6 months to finish the series. So you could give this alternative accelerated dosing in those populations. So you could do 4 doses, 1 on day 0, then 1 week later, and then at week 3, and then at day 30. So, and then they would need to come in for a booster, not really part of the initial series, but a booster shot at month 12, just to make sure that they maintain immunity. All right, so so moving on from hepatitis, now we're going on to human papillomavirus. And this additionally had a little bit of amendments to the schedule and the recommendations compared to previous years. So we now see that it's indicated in all persons living with HIV, as well as the general population, in anyone under the ages of 26, which is actually a good thing, because they're no longer saying, okay, in females up to 21 and males only if MSM to 26. They're simplifying the recommendation, which I think is a great thing for us to simplify, just to make it easier for us to follow. Sorry, the slide went ahead. Okay, so the new recommendation in June actually is also recommending for shared clinical decision making for individuals who are no longer age eligible for the standard recommendation. And so for individuals that are age 27 to 45 who are not adequately vaccinated against HPV, they can discuss with their healthcare provider to see if maybe they should get the HPV vaccine. And what's currently available is only the 9-valent vaccine. We used to have a quadrivalent vaccine available, Gardasil 4. However, that same company came up with a nonavalent or a 9-valent vaccine, which protects against an additional 14% of female cancers and 4% of male cancers. And so this is an added benefit. One thing I want to point out here is that the difference between the general population and the persons living with HIV population as it relates to HPV vaccine is the number of doses in the series. And this is really only relevant to the pediatric population, because in some pediatric population, if they start the series before 15 years old, they can get 2 doses. But really, we're talking about adults who would get 3-dose series anyways. And so 3-dose series is the only series that's really recommended in persons living with HIV. And again, the additional dose is to really ensure that they have an adequate immune response to the vaccine. So as far as the shared clinical decision-making for adults 27 to 45, this is a brand new recommendation. And this actually has been reported in the MMWR, so it's definitely official at this point. The HPV vaccination, though, when healthcare providers are discussing this with their patient population, really ideally, the best time to give this vaccine is in early adolescence, because vaccination is most effective before exposure to any human papillomavirus through sexual activity. And really, it has not been shown to be effective in treatment of human papillomavirus. So if someone already has the strain that you're vaccinating against, it really hasn't been shown to be helpful in that population for treatment of that. However, there are 9 strains in it, and so potentially there could be additional benefit if they're still sexually active. And if there's still a risk of exposure to other types of HPV, there could really be some added benefit of protection against these oncoviruses, right? Because HPV does lead to cancer. It's one of those cancer causing viruses. And so the big recommendation is really just for adults that are aged 27 to 45. They can discuss with their providers, and the clinicians can consider the potential benefit of vaccinating. All right, so influenza vaccine, and this is one that pulls on my heartstrings, just because as a hospital pharmacist, I see so many patients get admitted for the flu and for pneumonia due to the flu, that I just always think of, oh, I wish everyone got this shot and got vaccinated, because I really wish that we would see a reduction in our hospitalizations due to this type of infection. And so that's me on my soapbox, sorry. But influenza vaccine is incredibly important. One thing to note about that's a little bit different compared to the general population is that we do not recommend the live attenuated vaccine in persons living with HIV. So it's contraindicated. So none of the nasal spray. But it wasn't recommended 2 seasons ago because of lack of efficacy. So I personally am not a big fan of the nasal spray anyway. And so I do preferentially like the inactivated or even the recombinant or cell cultured types of influenza vaccine available. So the ACIP's recommendation overall states that you could potentially get the inactivated influenza vaccine or the recombinant influenza vaccine annually. There's no recommendation of one form over the other. So a little bit of the ABCs of flu vaccine abbreviations. I just included this here for completeness sake because I was using the IIV notation there. And you can see on the ACIP schedule, they do refer to these acronyms here. There's a bunch of different types of influenza vaccines that are approved and that are available on the market. And so there are some differences between them. And so sometimes you can get a trivalent vaccine, which includes 3 different types of influenza strains, and sometimes you can get a quadrivalent vaccine. Additionally, we have an adjuvanted vaccine as well as a high dose vaccine, and those are only indicated in our patients that are above the age of 65 currently. That's what their current indication is according to the FDA. All right, so looking at what's included for next year, or this year, actually, we're starting on, hopefully we're gonna get the flu vaccines in stock shortly. I know there was a slight delay because we did change a little bit our flu strains this spring, but what we ended up including for this year's influenza vaccine is 2 strains of influenza A, which is traditionally what's included. And so they did actually change both of these slightly from previous years. So they use they're using a Brisbane strain for the H1N1. And then they did change the H3N2 component to hopefully be a better match this year when we're looking at overall influenza. And then we have 2 B strains, which is also traditionally what's included on our quadrivalent vaccine. The one that's not in the trivalent is the one that was included the Yamagata strain, and it's no change from last season. Additionally, the Colorado strain is the same as the one that was last year, and that was the additional influenza B vaccine strain that's included. All right, so what's currently, well, sorry, I have a slide that's including what was available for the 2018 to 2019 season as far as what kind of vaccines were actually able to be purchased. And we should be seeing a list of what's available shortly once those vaccines are actually available to be purchased. They probably will be very similar to what I have on this slide. I have that we have the inactivated influenza vaccines, both the quadrivalent as well as the trivalent. I have that we have the adjuvanted one. One of the limitations is this is only technically approved for adults over 65. And then we have the inactivated quadrivalent vaccine, which is a cell culture based vaccine. And then we have the high dose vaccine, which last year was a trivalent vaccine. Additionally, we have the recombinant vaccine that's a quadrivalent vaccine that is also available. Okay, so moving on from influenza vaccination to another vaccine that's, again, recommended in the general population. And so getting the tetanus, diphtheria, pertussis vaccine is important for all patients, regardless of HIV status or not. It is recommended for a one-time dose for all adults. And additional doses might be indicated if a patient is pregnant or if they are caring for young infants in an effort to get that cocooning effect. And the two products that are available that are approved in adults are Adacil and Boostrix. And then for the tetanus, diphtheria alone component, which is recommended for a booster every 10 years, we have also two different vaccines available for that population. Moving on to the meningococcal vaccine recommendation, which is a little bit different, not a little bit. This is different than the general population, because in the general population, this is not the standard give to everyone. You need to have an additional risk factor in order to get the meningococcal vaccine as an adult. And so when we're looking at the meningococcal vaccines that are currently available, we have two different conjugate vaccines available, the Menactra or Menevo, and both of these require a 2-dose series that are at least 8 weeks apart, and you would need to get a booster every 5 years. Prior to about, I think it was 2016 or so, there used to be another type of meningococcal vaccine available, which was named Menimune. And this was a polysaccharide vaccine, but it's no longer available for purchase, and it's been removed from the immunization schedule. So if anyone was thinking about, oh, isn't there another one? That's no longer available. So we really just have these two. And aside from the conjugate vaccines, there is a new serogroup B alone vaccine that is viewed as optional for those aged 16 to 23. So this strain specifically tends to be the one that's more associated with the college age population and people that are living in close quarters like dormitories and those types of things. So that's really the population that usually we would recommend this vaccine in. And they do recommend if you start with one of these, like the Bexsero, then you need to continue with that when you're looking at to get the 2 doses. And so you don't want to, they are not interchangeable. All right, and so childhood vaccines that could be considered in patients living with HIV, if they have a CD4 count that is greater than 200, or the CD4 percentage also needs to be greater than 15%, they would be eligible for vaccines with some of our live vaccines to protect against some of the childhood diseases. And this is probably more important sometimes, especially in areas where there might actually be a current measles outbreak, which we've had in certain pockets of the United States due to waning immunity potentially, and also due to lack of immunization and lack of herd immunity. And so the MMR vaccine does help protect against measles, mumps, and rubella. And it is recommended for anyone who was born after 1957, because if they were born before 1957, it is assumed that they may or may not have already been exposed to these viruses. But if anyone also has proof that they're not immune to these diseases, they could have an indication to get this vaccine. It's a 2-dose series, and you do need to separate it by at least 4 weeks. And so that's what we usually give in our adult population living with HIV, is a 2-dose series of the MMR vaccine. And then additionally, we would recommend the varicella vaccine for those who don't have evidence of immunity to varicella, which varicella causes chickenpox for those. So next, we're going to discuss a couple clinical controversies related to immunizations in persons living with HIV. So what about the shingles vaccine? So this is something that a lot of providers will ask me questions, especially as our persons living with HIV are aging, right? And so we're seeing geriatric patients, right? And we're wondering, well, what do we do about this shingles, right? Because a lot of our patients had chickenpox as a child, so they're definitely at risk of getting herpes zoster activation, right? Or reactivation of the zoster virus, right? And so unfortunately, ACIP has no recommendations related to the new herpes vaccine or the new herpes zoster vaccine, available for its use in persons living with HIV. And I included on the schedule to just show you that they kind of leave it blank here. It's these gray boxes. And so unfortunately, we really don't have that much guidance in whether or not we really should be vaccinating our patient population against this disease. In the general population, what I can say is that for adults that are aged 50 years and older, it is recommended to give a 2-dose series, and they preferentially recommend to give the new recombinant zoster vaccine, which is named Shingrix, and it's supposed to be given 2 to 6 months apart. So it's a 2-dose series given 2 to 6 months apart. And they do recommend the RZV, or the recombinant one, over the live one for the general population. And one thing I would say is that previously the live vaccine was the only one available, and this was and still is contraindicated in persons living with HIV who have a CD4 count of less than 200 cells. So I have to put this, it's still a question. What should we be doing for our shingles vaccination in our persons living with HIV? We're still waiting on a little bit of guidance to discuss whether or not we really should be recommending Shingrix in this patient population. One thing I wanted to point out is a recent study did show that herpes zoster and herpes zoster vaccine rates among persons with HIV are lower. And so we do need to see if we should be targeting, and not necessarily targeting, but making sure that we're offering this vaccine rather to our persons living with HIV if they have an indication for it. So one of the other clinical controversies that some might discuss would be, what should we do about the hepatitis B vaccine? Because for those who have been practicing in the HIV field for a while, and even maybe those who have been working in the HIV population for not a while, you may have noticed that even if you do complete a hepatitis B vaccine series, you might actually not get that really good titer of hepatitis B antibodies after the series, because some patients really just don't respond well to the vaccine. And so unfortunately, the humoral response to hepatitis B vaccine is reduced in children and adults who are immunocompromised. And we know that HIV does cause immunocompromise. And so modified dosing regimens, including doubling the dose of the standard antigen, so getting that 40 microgram antigen dose, or administering additional doses like a 4-dose series versus 3-dose series, they might increase response rates. But the problem is that data of the response to these alternative vaccine series are limited when we're looking at the schedule of whether or not it actually changes the response rate or not. There was a meta-analysis that was published in 2013 that was looking at 5 clinical studies in persons living with HIV. Most of them were actually hepatitis B vaccine naive additionally. And they were looking at high doses versus standard dosing of the vaccine. And some of them actually got a smaller standard dose, which is more for pediatric dosing. And they ended up, of an N of 888, they saw a significant increase in response rates using the higher dose vaccine. And the odds ratio was about 1.96. So this does tend to potentially favor using a higher dose vaccine in this patient population. Now, when we talk about some other controversies, we do have to talk about influenza vaccine efficacy. And this is a topic that I think is getting more attention more recently. And there actually have been a number of publications coming out of CID and some other infectious disease journals on different strategies to try and increase our influenza vaccine efficacy rates. The efficacy of influenza vaccination among HIV infected or persons living with HIV is reduced compared to persons not living with HIV. And so we do know that HIV status does impact the ability for the influenza vaccine to really be highly efficacious. There are some strategies that have been used to try and improve efficacy, potentially using the higher dose or 4 times the amount of antigen. This is not currently FDA approved when we're looking at it though. So the high dose influenza vaccine is only approved for those who are 65 and older. However, there are some studies that have looked at using this in the HIV in persons living with HIV, even if they're younger than 65. Also, optimizing timing of the influenza vaccine. So sometimes we have dual peaks of influenza outbreak, which happened recently. Actually, this past year, we saw a high level of influenza activity around October, November of last year, and then we saw another increase of influenza activity. Another wave started in like February or March. And so there have been some strategies to try and improve the timing, because some patients, their immune response or their titers of antibodies as a response to influenza vaccine decrease. Some patients, it decreases within 6 months of vaccination, and some patients it takes a whole year. And so it's very patient specific whether or not the timing is really relevant or not. And so there have been studies looking at it. And so right now it's still a clinical controversy. I really wouldn't recommend one time over another as far as time of the year. I recommend people get influenza vaccine when it's available in the fall. And so that's what I currently recommend based off the evidence and based off of ACIP current recommendations. Now getting to one of the things that I want to point out is barriers to vaccine uptake in persons living with HIV, and talking about some reduction strategies to help decrease disparities in our minority populations. There have been a few studies looking at trying to reduce barriers to specific types of vaccine uptake in our HIV and our persons living with HIV population. And one study recently published in 2018 was looking at foreign-born Latino HIV-infected gay and bisexual men, and looking at what are their perspectives on preventing anal cancer. And one thing I want to point out is anal cancer is rare. It's only 0.5% of all new cases of cancer. However, the majority of anal cancers are vaccine preventable diseases, because they're caused 91% of the time by HPV strains 16 and 18, which are included in our HPV vaccine. So HPV vaccination is the primary prevention tool that we really need to be recommending to all patients. Additionally, anal screenings are the secondary prevention tool for anal cancer. Catching it early and making sure that we're able to treat it adequately and locally, hopefully before it metastasizes, is always going to be a good idea for any type of cancer. So for those who are HIV infected, MSM, these are the populations that are most at risk of anal cancer. And this is potentially due to the fact that HIV causes immunosuppression, anal sex receptivity is an additional risk factor, and exposure to multiple high-risk HPV strains are also additional risk factors for anal cancer. The study design of this study they included patients who are HIV infected, who self-identified as gay or bisexual men, who were adults, so 18 years and older. And they also had to be fluent in Spanish because this was a study that was conducted in Spanish. So they used Spanish flyers and those types of things. Additionally, this study was conducted right in my area in Miami-Dade County. And so it was the inclusion criteria were those who live in Miami-Dade County. Exclusions included the research team really only analyzed interviews of transcripts for those who identified as foreign-born Latino MSM. And the study design was really a qualitative in-depth interview. So this was not just a select A, B, C, D. This was really trying to get at what is really going on in this patient population. Like, what are perspectives of things that would make you more likely to get the vaccine, as well as what do you think was preventing you from getting the vaccine in general? So they looked at 33 people, and out of that, when I wanted to talk about some of the barriers to the HPV vaccine uptake, the main thing it boils down to is knowledge, right? And so I want to point this out. It's a knowledge barrier, and that's a big thing. We really need to make sure we're getting the knowledge out there. Well, what do I mean by knowledge? So roughly half of these patients have heard of HPV. And 15 of them described that HPV is transmitted sexually. Really, we should have 33 of them saying that they know this is transmitted sexually, right? So this should be a common knowledge thing. And additionally, we would hope that everyone has heard of HPV. It's one of the most common sexually transmitted diseases out there. 5 of those 15 who described that HPV is transmitted sexually had never heard of the HPV vaccine. And 4 of them actually thought it was only for women. Like, HPV is only a women's health issue and men don't have to worry about this virus. Unfortunately, 15 of the 33, only 15 of them had heard of the HPV vaccine. And when we're looking at it, well, how did they hear about it? The main source is us. Healthcare providers are the main source of how they learned about it. So again, this really highlights we got to talk to our patients about this, right? We've got to be involved. Additionally, 4 of them said they heard it on a public service announcement from the TV, and 2 of them actually found it from watching the news. There were some single answer responses about newspaper ads or health-related conferences, and 1 person said they heard about the HPV vaccine in a HIV support group, which is a great thing as well. Only 1 participant out of all 33 had received a single dose of HPV vaccine, which it would be recommended to get a 3-dose series, right? Because our persons living with HIV really need that 3-dose series to get an adequate immune response. And 9 men had been age eligible to receive the vaccine. And so when we're looking at of the 33, there were people that were included that were not age eligible, at least at the time of that study. So the greatest barrier that this study showed was lack of knowledge about this resource. And that was an N of 10 of the 33. They self-identified. They were like, well, I just didn't know. Additional barriers that were discussed in the study, which I think are things that many healthcare providers are already aware of, is insurance coverage, fear of side effects like fear of the vaccine itself, and then potentially that they have a current low immune function. So that was why they wouldn't want to get any vaccine, is that maybe they just didn't think it would work in them because they had a low immune function. There's really a need for increased health outreach and increased provider recommendations to receive the HPV vaccine, because the study does suggest that they would listen to you. They will listen to us if we talk to them about it, and making sure that they actually know about it, because this study really did show us that a lot of people are unaware of this disease and of the risks that it can pose, especially in our more susceptible population. And so there's a couple things that could be done. Some outreach things that were suggested were even going out in a van to hand out flyers and things. But some of the best methods are really making sure that we tailor these in culturally and linguistically appropriate methods. Another recent study looked at barriers to meningitis vaccine uptake, which again is another vaccine that's recommended in our HIV population. And so this study was done in Chicago, actually during a time where they had a serogroup B invasive meningococcal disease outbreak in the MSM population. So it was widely discussed on the news and local areas about this outbreak. And so they kind of did figure, okay, well, everyone should be hearing about this. This study was looking at specifically Black MSM populations, as well as MSM populations that are living with HIV. And they were hoping to see if they could increase their vaccination rates. So the study design was 4 focus groups, and it was in Chicago during the outbreak. It was mostly open-ended questions, so really trying to get from them some answers to try and figure out how can we reduce these barriers. Again, these were adults. They were male at birth, and they resided in Chicago, and they had to have been sexually active with a man at least 6 months prior and English speaking for the purposes of the interviews of the study. And really what the objective of this was to inform the development of a new intervention strategy to increase vaccine uptake. So they looked at 29 men, and the majority of the participants identified as non-Hispanic Black, with approximately half of them self-identified as HIV positive. The main barriers that I want to point out are fear. So some people had fear of adverse drug effects or adverse reactions to the vaccine. Some were scared of needles, and some were scared that getting this vaccine would disclose their MSM status to the rest of the world. Something I wanted to point out is that there was a barrier that was noted as a distrust of medical providers in the Black MSM community, but not in the HIV positive group, which actually the interesting thing that I found were participants in the study from the HIV positive group. One of them specifically said, I immediately took it. My infectious disease doctor keeps me informed of whatever she comes across. Based off her information, I said, go ahead and give me the vaccine. And so there's something to be said for the fact that it did appear in this study, at least, that the HIV positive group did not feel that distrust of medical providers was a reason they wouldn't get the vaccine. They actually said, whatever my HIV doctor says, I would like to get. Fear of the impact on the HIV meds and the immune system was additionally something that was discussed only in the HIV subgroup and not in the other patient populations. One last thing I want to point out is facilitators of vaccines. How do we get these out there? How do we help people getting them? Making sure that we have them available, making sure they're accessible in any location that the patient can get to. And the influence of vaccine requirements are also facilitators of vaccines. So if some of the participants said, well, if I had to get it for school, I would get it. And so thinking about those types of things, actually that seems to facilitate vaccine uptake.
Hello, so we are going to open the floor now for questions. Actually, we do have some questions from the board that we want to get to, Dr. Worley. Thank you so much for this amazing topic. I think it's so relevant to what we're going on today. I have some questions here, and feel free to type them, any more relevant questions that you have in the Q&A or chat box. So I have here one question says, which one, HRSA, CDC's, or other, is the most recommended standard vaccination guidelines used by HIV care providers in the U.S.? And how are agencies set their performance scale to measure their performance on vaccination?
Well, I would say that the current standard is to follow the ACIP CDC recommendations as it comes to vaccine recommendations. And I do believe the IDSA preventative guidelines even reference that, to follow the current ACIP vaccine schedule.
Thank you for that, Dr. Worley. There's another question that states, in community pharmacy, do we need a prescription to give a Hep A and Hep B vaccine to people living with HIV, or can we just consult Florida shots or confirm with MD verbally?
Oh, that's great that you said what state you are. So it's state dependent on whether or not you need a prescription. In Florida, because we are allowed to give vaccines according to our state regulating agency based off the ACIP schedule, as long as you have in your pharmacy a protocol for Hep A or whatever vaccine, you would be able to give that vaccine if they have an indication from the ACIP CDC schedule without an extra prescription. And yes, you would need to consult. In Florida, we consult Florida shots to look for vaccine history.
Thank you so much for that, Dr. Worley. Want to just open up the floor to any other participants that have more questions. if you can type them in the, it says, should all the vaccines be given concurrently?
I would not recommend giving all of the vaccines concurrently on one visit. I don't think that most providers would feel comfortable doing that either. So I think it would be a strategy that would be a tiered approach based off of the risk of whatever disease it is that you're vaccinating against. A lot of these can be given together, and I would recommend consulting your pharmacist to see which ones have safety data on giving them together at the same time, because there's some vaccines that you don't want to give them at the same visit, and it would be depending on which vaccines are indicated in that patient. So it's kind of a no, you don't want to give every single vaccine on the planet together, because there are some vaccine-vaccine interactions.
Perfect. Just want to open up to see if there's any other. Okay, do insurances. Okay, we have a couple more.
Yeah.
And then we have, okay.
So I would say, in general, almost all health insurances cover most of the preventable medicine things such as vaccines. Now, is it 100% covered? That's going to depend on the insurer. Whether or not they have a copay that they require with the vaccine will depend on the insurer. But for the most part, the insurance companies will be on board with the ACIP recommendations as it relates to vaccine recommendations.
Well, thank you so much, Dr. Orley. This has been a tremendous webinar. Again, this topic is so relevant to our current state and as providers. So I just want to thank everybody for attending. Thank you for being patient with this new system, and thank you just for being with us. Right now we're out of time, and I just want to make sure that you know that there will be an evaluation link that will appear at the end. If not, please make sure that you keep in with your emails. I will be sending emails out with evaluation link. Remember, the evaluations just reflect on your time here and how this is relevant to your practice, and also for CME credits. Thank you very much for attending, and have a great day.